Good afternoon, honored Professor Dorling, fellow colleagues and guests. This is our third session of our training course, and today we're focusing on the management of adult arterial hypertension. I'm Zhu Zhili from Fuwai Hospital. So let's review our course on the classification and stratification of hypertension. Hypertension is defined as a clinic systolic blood pressure over 140 millimeter of mercury and or diastolic blood pressure over 90 without the use of antihypertensive medications. So although the definition or diagnosis of hypertension is mainly based on the repeated measurement of office blood pressure, the out-of-office blood pressure is increasingly emphasized because of the advantages in evaluating all-time blood pressure, the nocturnal blood pressure, that is blood pressure during the night, and also to diagnose the masked hypertension and also the white coat hypertension. So according to the guidelines, hypertension can be diagnosed with either ambulatory blood pressure measurement monitoring or home blood pressure monitoring. If the patient has a home blood pressure monitoring over 135 over 85 millimeters of mercury, or have a ambulant blood pressure monitoring, that is the 24-hour average of blood pressure over 130 over 80 millimeter of mercury, or daytime average over 135 over 85, or nighttime average over 120 over 70 millimeter of mercury, then the patient can be diagnosed with hypertension. After the patient is diagnosed with hypertension, then what we should do next is the risk stratification, because the strategy of pharmacological treatment depends not only on the blood pressure per se, but also on the overall cardiovascular risk. We should comprehensively evaluate the cardiovascular risk stratification of hypertensive patients so as to determine the timing to initiate the antihypertensive therapy and to optimize our treatment regimen and to establish a more appropriate blood pressure control goal and to perform comprehensive management for the patient. So according to the guideline, if a patient have a clinical cardiovascular disease, that is, if the patient is already diagnosed with previous myocardial infarction or has a clinical diagnosis with coronary heart disease or TIA, or if the patient is diagnosed using angiography or ultrasound, then the patient can be evaluated as having very high risk of cardiovascular disease. Also, if the patient have diabetes with target organ damage, such as grade 3 hypertension or CKD, severe CKD, that is eGFR below 30, then the patient also belong to this category. If the patient is stratified as having high risk of CVD, then the patient will have a very marked elevation of single risk factors, such as the total cholesterol over 8 millimole per liter, or have grade 3 hypertension, that is blood pressure over 180 over 110 millimeters of mercury, or patients with diabetes without the target organ damage. Also in patients with left ventricular hypertrophy or moderate CKD, that is eGFR between 30 to 59. And if a patient have a grade 2 hypertension without the above risk factors, then patients, especially many middle-aged people, belong to this category, the moderate risk category. So after the diagnosis and also the risk stratification of the hypertensive patient, then we should give our therapy, antihypertensive therapy, in which the lifestyle modification is the basis for the antihypertensive therapy. It should be applied to all hypertensive patients, including normal high-value patients and also hypertensive patients that requires medication. The aim is to lower blood pressure and to control other risk factors and also other clinical conditions. The main measures include reduce the sodium intake that according to WHO, the daily salt intake should be below 6 grams, and also increase the potassium intake. The patient also should also have a reasonable meal and balanced diet, and to control body weight to make BMI below 24, as we know according to the WHO. For Asian people, BMI above 25 should be diagnosed with overweight, and the BMI over 28 should be diagnosed with obesity. And for male, the waist circumference should be below 90 centimeters. For female, that measure should be below 85 centimeters. Also, the patient should quit smoking, especially avoid passive smoking, because for some female patients, they may not smoke themselves, but their family members may smoke, and passive smoking is a very damaging risk factor. Also, the patient should quit or restrict soft drink smoking, and also do more exercise that is with medium intensity 4 to 7 times a week, and 30 to 60 minutes each time, and also to reduce the mental stress and maintain psychological balance. Each lifestyle intervention may have different strength on the control of blood pressure. For instance, to reduce sodium intake, that is to control salt intake below 6 grams per day, can have a 2 to 8 millimeter of mercury reduction on the systolic blood pressure in patients. And also weight loss is a very important lifestyle intervention. Every 10 kilo of weight reduction will help the patient to reduce their systolic blood pressure between 5 to 20 millimeters of mercury. And also regular exercise may reduce systolic blood pressure by 4 to 9 millimeters of mercury. Then, what drugs or medication should we apply to hypertensive patients? All 5 classes, including ACEI, ARB, CCB, beta blocker, alpha blocker, and also diuretics, are suitable for initiation of an antihypertensive therapy. But the choice of medication should be depending on the person's special population, comorbidity, and also their blood pressure levels. Ordinary patients should start with regular dose, while the elderly patients should initiate with the lower effective therapy dose, especially in elderly patients that is fragile. It can be considered to gradually titrate to the full dosage according to the treatment demand. And it is also preferred to use long-acting agents to control 24-hour blood pressure, because that could increase the patient's tolerance and also the willingness to take the medication. And it's also recommended that the high-risk group of patients with blood pressure over 160 over 100 millimeters mercury, or have a blood pressure that is 20/10 millimeters of mercury higher than the target blood pressure should receive medications. People could receive a monotherapy or small dose combination therapy depending on their personalized conditions. So people with different clinical conditions have different favorable antihypertensive drugs depending on their conditions. For instance, in patients with left ventricular hypertrophy, ACEI or ARB or CCB, the calcium channel block, are suitable for this group of people. And in patients with heart failure, then ACEI and ARB are suitable, but CCB and should not be considered. And in patients with diabetes, ACEI and ARB should be considered because they have little adverse effect on the metabolism. But beta blocker, which has adverse effects on the glucose metabolism, should be less considered. Now, let's discuss the all 5 types of antihypertensive medications. CCB can be classified into 2 groups, the dihydropyridine CCB and also the non-dihydropyridine CCB. Dihydropyridine CCB is more commonly used for antihypertensive medications. It is particularly suitable in elderly patients and also patients with peripheral vascular disease and also isolated systolic hypertension. And it is also suitable for patients with coronary artery disease and also carotid atherosclerosis. The mechanism of CCB is to dilate blood vessels so as to lower blood pressure by blocking calcium channel on the vascular smooth muscle cells. The common side effects of CCBs are the reflex sympathetic activation leading to rapid heartbeat, facial flushing, edema of ankle, and also hyperplasia of gums. There are no absolute contradictions for the dihydropyridine CCBs, but in patients with tachycardia or heart failure, this group of people should use dihydropyridine CCB with caution. Non-dihydropyridine CCB can also be used to control blood pressure, but it's less commonly used. But in patients with atrial and ventricular block, especially grade 2 or 3, and in patients with heart failure, this CCB should be forbidden. ACEI and ARB is another important group of antihypertensive medication. ACEI inhibit angiotensin converting enzyme and ARB blocks the angiotensin 2 type 1 receptor so as to inhibit the ROS system. These 2 categories of antihypertensive medications are particularly suitable for patients with heart failure, coronary heart disease, and also patients with diabetes, as they have little or no adverse effect on the metabolism of glucose and lipid. But also, we should note that patients use ACEI may have side effects, including dry cough, which often appears at the early stage of medication. If patients have dry cough, then the patient can convert to ARB, which have less side effects, but are more expensive. Both of these drugs have side effects of hyperkalemia. So in patients with hyperkalemia, they should not be used. And also in patients with bilateral renal arterial stenosis, these 2 drugs are have absolute contradictions, and they also should not be used in patients with in pregnant female patients. Diuretics mainly increases the sodium efflux, and also so as to reduce the load burden of the patient. These include these three types, including the thiazides, the loop diuretics, and also the anti-aldosterons. They can be used in patients with heart failure so as to reduce the blood pressure, and also the patients after the myocardial infarction. But we should note in patients with gout, thiazide diuretics should not be used because it has absolute contradictions and should be used with cautious in pregnant patients. In patients with gout, loop diuretics, including the can be considered. And in patients with resistant hypertension or heart failure, anti-aldosterone diuretics can be considered, but cannot be used in patients with renal failure or hyperkalemia because it has the effect of increasing the blood potassium level. Beta blockers are particularly suitable for patients with coronary heart disease, including angina pectoris and post-myocardial infarction patients, and also patients with faster heartbeat and also chronic heart failure. But beta blocker has side effects as to decrease the heart rate and also increase the transmission time between the atrial and ventricles. So patients with AV block, especially degree 2 or 3, should not use the beta blocker, and patients with asthma, beta blocker is also forbidden. Patients with COPD should use beta blocker with cautious. Alpha blockers are particularly suitable for patients with prostatic hyperplasia and also hyperlipidemia, but it has a side effect of increasing the chance of orthostatic hypertension. So if the patient should use alpha blockers, they should take the medication before sleeping so as to reduce the chance of orthostatic hypertension. So the goal of hypertensive therapy is to reduce the overall risk of developing heart, brain, kidney, and vascular complications, and also to reduce the overall death rate. The benefit of antihypertensive treatment derive primarily on the blood pressure reduction per se, and also on the lifestyle improvement or interventions is the basis of hypertensive therapy. Antihypertensive drugs should be considered according to the overall risk levels of hypertensive patients and to control the correctable risk factors, also to modify target organ damage and existing clinical diseases. Also, intensive hypertensive treatment strategies should be applied to achieve maximum cardiovascular benefit. For the general population, the goal of antihypertensive treatment is to below 140/90 millimeters of mercury. And if the patient can tolerate the antihypertensive medication, then the blood pressure should be gradually reduced to below 130/80 millimeters of mercury. In addition to besides the hypertensive emergencies and hypertensive urgencies, that is patients with very high blood pressure, often above 180/120 millimeters of mercury, with or without acute target organ damage, for instance, pulmonary edema or heart attack. Then most hypertensive patients' blood pressure should be gradually reduced to the target level within a bracket of 4 to 12 weeks, according to their conditions, whether they can tolerate the blood pressure reduction and whether they are elderly patients or whether they are fragile. And also the timing of hypertensive drug therapy is also important. In patients with a blood pressure below 160 over 100 millimeters mercury or have lower blood pressure according to their target BP or at low to medium risks, then monotherapy could be beneficial, or they could also choose to use low dose combination therapy. All 5 types of antihypertensive drugs can be used. If a patient has relatively high blood pressure, that is above 160 over 100, or have blood pressure 20 over 10 higher than the target BP, or at high risk of risk stratification, then the patient should initiate combination therapy, that is whether C plus A, that is CCB, accompanied by ACR-ARB, or ACR-ARB plus diuretics could be used as a first-line combination therapy. Also, it's more often seen patients with hypertension to have other comorbidities such as hyperlipidemia and also atrial fibrillation, etc. For patients with both hypertension and hyperlipidemia, they should be actively treated with hypertensive therapy, and also a moderate lipid-lowering therapy should be considered with, in addition to their lifestyle interventions. In low to intermediate risk ASCVD, when blood lipid levels cannot reach the target value after the strict implement of lifestyle interventions for 6 months, then drug lipid lowering therapy should be considered. For patients with hypertension at a risk of ASCVD, then statin therapy should be initiated immediately. Moderate strength statins can be used if the cholesterol-lowering drug can be combined with when necessary. Also, in patients with hypertension and associated with ischemic cardiovascular diseases, then antiplatelet therapy, mainly the aspirin, should be considered. Also, in patients with diabetes, the target blood glucose control level is a fasting blood glucose level between 4.4 to 7 millimole per liter, or a 2-hour blood pressure or peak blood pressure below 10. The target blood glucose control could be more relaxed patients that is prone to hypoglycemia, or with long course of disease, or in patients with older age, or with comorbidities of various complications. The HbA1c should be below 7%. And also in patients with AF, the atrial fibrillation, then they are recommended to use RAS inhibition drugs, especially the ARB, to reduce the occurrence of atrial fibrillation. If they should use anticoagulant therapy according to the current guideline, then they should be used according to the guideline. So, lifestyle intervention is the basis of cardiovascular disease prevention in hypertensive patients with multiple risk factors, as we have stated in the previous slides. And it is also suggested that hypertensive patients with elevated homocysteine levels, that is often referred to as the H hypertension, should be supplemented with fresh vegetables, fruit, and also folic acid if necessary. So, if a patient is newly diagnosed with hypertension, then we should evaluate patients with cardiovascular risk factors, their target organ damage, and also clinical disorders, so as to stratify patients to categories of very high risk, moderate risk, or low risk. If a patient is classified as very high risk or high risk of CVD, then we should start the antihypertensive drug therapy as soon as possible. In patients with moderate risk, then we should monitor their blood pressure and other risk factors for several weeks using the ambulatory blood pressure monitoring or home blood pressure monitoring. If the blood pressure does reach the BP target, then we should keep home monitoring. If the BP does not reach the target, then we should start the drug therapy. And in patients with low risk, we can monitor their blood pressure and other risk factors for relatively longer time, between 1 to 3 months, and also using ABPM and also HBPM to monitor their blood pressure. If the blood pressure does reach the targets, then we should keep on monitoring. And if the blood pressure does not reach target, then we can consider using low dose or monotherapy drug interventions. So this is all I'm going to share with you today. So thank you.